Bem-vindos ao grande round dos Policlínicas de Porto Alegre, em colaboração com a Faculdade de Medicina da Universidade Federal do Rio Grande do Sul. O encontro de hoje será sobre oncologia global. Ele estará sendo conduzido em língua inglesa e, na sequência, vou estar fazendo a conversão da linguagem. More than 100 years ago, in 1913, a group of 10 physicians and 5 lawyers found the American Cancer Society in New York City. This is a very important milestone because at that time, cancer was associated with death. Today, reaching nearly 110 years, American Cancer Society has a history of making a strong contribution to prevention, diagnosis, and treatment of cancer, which has resulted in a 32% drop in the overall cancer mortality rate in the United States. In 1964, a group of 7 physicians came together in Chicago, Illinois, and created the American Society of Clinical Oncology, which has grown from the original 7 American founders to nearly 47,000 members today, including more than 15,000 international members. Through Concord Cancer Foundation, Asco directly funds more than 400 researchers annually, including about 100 younger investigators. Through the pillars, which are education, research, and quality, combined with a strategic plan that challenges it to make a global impact, Asco is committed to improve the care delivered by members around the world. Both organizations participate in historic breakthroughs in the fight against cancer and are making a very important contribution to cancer control around the world. Recent advances in molecular biology, target therapy, and cancer immunotherapy have opened a new window of opportunity for more efficient and less toxic personalized treatments. Were made available a large amount of data. Today, clinical oncology has to deal with international big data. The specialty has become a new biomedical ontology. IT resources must be incorporated using advances in artificial intelligence, searching for a model of united knowledge. Now, I'm proud to announce in today's HCPA Grand Round a challenge named In Search of Global Oncology. Will participate in this meeting Julie Grallow, Chief Medical Officer, and Executive Vice President of American Society of Clinical Oncology, USA, Karen Knudsen, Chief Executive Officer of the American Cancer Society and Cancer Action Network, USA, Daniela Rosa, Professor of Clinical Oncology at our University Hospital and President of Brazilian Breast Cancer Study Group. I'm James Fleck, and I will conduct the meeting both as a chairman of the Grand Round and a full professor of clinical oncology at our University Hospital. Before starting, I would like to thank very much Dr. Clifford Hughes, CEO of Asco, for his tireless, attentive, and qualified technical and emotional support to make this meeting a reality. Now, let's start with Dr. Grallow's presentation.
Thank you very much, Dr. Fleck. And I will screen share now. Good morning to everyone, and thank you for the invitation to present at your Grand Rounds. We're talking about a search for global oncology, and I'll be reviewing ASCO's Make a Global Impact strategic goal. As Dr. Fleck has already told you, although we have American in the name, we are not just North American. We are global. We have more than 45,000 ASCO members spanning 150 countries. Our annual meeting attendance is generally 40%, and our membership is a third international. This is a busy slide that has our mission, vision, core values, but I point out on this slide that one of the 4 goals of our current strategic plan is indeed to make a global impact. And we hope to do that across all three of our mission pillars: research, education, and quality. With respect to research, we have international research courses, international innovation grants. We have Young Investigator Awards that are targeted to global oncology work. We have Life Awards, the long-term international fellowship. And we have our Journal of Clinical Oncology's newer journal, JCO Global Oncology. Under our education mission pillar, we have our IDEA, our International Development and Education Awards. We have virtual mentoring available, international courses and e-courses. We partner with Project ECHO in supplying education remotely. We have a breakthrough meeting held in Asia. We'll have our next one in Japan next year. We have a Best of Asco International series. And within our annual meeting held in Chicago every year, we have a global health education track and multiple global webinars. Under our quality mission pillar, we have our international COPI, our Quality Oncology Practice Initiative, and COPI certification. We have quality training programs internationally, resource stratified guidelines. We have our international cancer core sites in low and lower middle income settings, and we are a partner in the CCAN City Cancer Challenge. A few years ago, Asco decided to create regional councils to increase our engagement with our international members. The first international council to be convened was the Asia Pacific Regional Council in 2019, and the second was our Latin America Regional Council, which we convened last year. We will be announcing our Sub-Saharan Africa Regional Council later this year. And while we had plans to convene a Central and Eastern Europe Regional Council earlier this year, that has been put on hold due to the war in Ukraine. The role of our regional councils is to advise ASCO on the needs and challenges for members in specific regions, to identify and adapt ASCO programs and services to the region, to identify opportunities and learnings that could be applied within the region, to serve as a forum, to network, to collaborate, and to develop local solutions together, and to raise awareness and increase engagement within the various countries within a region. ASCO currently has approximately 2,000 members from Latin America. And this is a picture from just last month in Miami, Florida, of the ASCO Latin America Regional Council. And the current representative from Brazil is Dr. Rodrigo Munhoz. So if you have ideas, questions, suggestions for the Regional Council, then you can submit them through him. In the area of leadership development globally, I've mentioned our International Development and Education, or our IDEA Award. Over the past 10 years, we've had 405 IDEA recipients. And the map in blue, you can see the countries that were represented from our IDEA recipients. 70 countries have had IDEA recipients. And we use our IDEA recipients who are generally early in their career. They come from a lower middle income country, and we bring them to our annual meeting. We pair them with a mentor, and they actually then have travel funds to go to the mentor's institutions for a few days after our annual meeting. We use this pool of IDEA recipients. They truly are the up-and-coming leaders in their countries. We use them as volunteers and to support ASCO programs. Indeed, the current chair of the Latin America Regional Council, Yanin Chavez Guerrera, was my IDEA recipient about 12 years ago now. Within the area of global quality, we have our quality training program that we call QTP and our Quality Oncology Practice Initiative, COPI. Internationally, we have QTP, quality training programs that can be spread over 6 months or just a one-day format. And generally, an institution submits an application. It's led by an oncologist, a physician at the institution, but it brings a whole team, and they focus on specific quality improvement activities. Since 2016, we've had 270 international participants in our quality training program spread across 9 countries, the flags of which are represented here, and there's Brazil right at the top. Within our Quality Oncology Practice Initiative, or COPI, we have a certification program. The certification it lasts for 3 years, and then it's renewed. You need to have a high score on a select set of quality measures, and you have to meet 25 Asco and Oncology Nursing Society chemotherapy delivery safety standards. And we actually currently have 13 Brazil sites with COPI certification, although I don't see any in Porto Alegre. So we can discuss that. I'm proud to announce that in June, we signed a Memorandum of Understanding with the World Health Organization, and this is also focused on global quality. Our joint project description in our MOU is to improve access to quality cancer services as part of universal health coverage. Output number 1 is to prioritize and align indicators that can be used in WHO tools and in ASCO activities. And we will start with the primary focus on breast cancer and palliative care. These are 2 of WHO's high priority areas. Output 2 is we will then have case studies summarizing policy and or programmatic responses to quality improvement and disseminate these through WHO and ASCO networks. In the area of global education and leadership development, I'll highlight the City Cancer Challenge, CCAN. As I'm sure you're all aware, Porto Alegre is one of the 11 current cities that are part of the current City Cancer Challenge. ASCO is a leading partner in CCAN, and it provides CCAN cities with education and access to ASCO resources and programs. We have a planned ASCO CCAN multidisciplinary cancer management course that will be in Porto Alegre at the end of October of this year, and I will be visiting your city as part of that course. I also want to highlight that we have a CCAN Women's Leadership Development course that will officially kick off at the World Cancer Congress in Geneva in October. And we will be notifying the applicants who are selected for this women's leadership course within these CCAN cities in the next week or 2. Now, we always want to hear from our members, and last year we did a survey. We focused in 3 major regions. One of them was Latin America, and surveyed our members. And one of the questions was, how can ASCO add value to you, your patients, and cancer care in your country? And the number 1 answer was access. We could help with access to essential drugs, but also the need for tumor registries and the need for pathologic diagnosis was rated quite highly. So at our ASCO 2022 board retreat this past March, we focused on Pillar 4 of our strategic plan, Make a Global Impact, and had 3 breakout areas where we thought ASCO could help make a global impact: international education, global access to essential treatments, and international leadership development. As a result of this middle box, global access to essential treatments, we held a stakeholder summit on access to essential cancer medicines at our annual meeting in June in order to try to bring together the stakeholders working in this area and learn what was going on and what was planned. As part of that stakeholder summit, we took a step back and looked at all of the components necessary to have access to cancer drugs and cancer treatment. It's not just about the cost that's prohibiting many patients from getting access to treatment. We talked about how do we define the highest priority cancer drugs, and we are starting with a basis of the WHO Essential Medicines List. We talked about the affordability of drugs, not just the drug cost to the payer, whether it's the country or insurance, but patient out-of-pocket costs. We talked about how to get access to cancer drugs, how to include them in budgets, national cancer control plans, insurance coverage, and then how to procure and transport them. We talked about assuring the quality of cancer drugs through registration at a national level and regulatory oversight. We talked about how to optimally deliver cancer drugs with the healthcare workforce, health systems infrastructure, chemotherapy safety standards. And we talked about how to optimally use drugs. It's not just about getting access to a drug, but knowing what disease and what setting it has the most benefit. And this would be through guidelines and pathways, availability of biomarkers to select appropriate drugs, and through monitoring and evaluation. We have, at Asco, have partnered with the International Union for Cancer Control's ATOM Coalition, which stands for Access to Oncology Medicines. This was launched in May of this year at the World Health Assembly with a goal to increase access and availability of cancer medicines on the WHO's Essential Medicines List in low and lower middle income countries. And the strategy will be to use innovative and multi-sectoral access mechanisms and bring together partners with expertise and track records in addressing key access barriers. These are the member organizations that have signed on to date and the companies at launch. Asco is a proud member. And the idea behind ATOM is, one, to improve the capacity of these low and lower middle income countries to receive and use cancer medicines through capacity building, education. We will start with 5 to 10 countries, with the goal being to grow to 40 plus. Then we want to make available WHO Essential Medicines List medicines, generic, biosimilar, with a plan to add some innovative medicines that are left off of the Essential Medicines List solely because of price, not because of efficacy and toxicity. There will again be an initial focus on breast cancer, with plans to add prostate, cervical, lung, colorectal, and pediatric. There is engagement with the generic and biosimilar manufacturers and engagement with the originator companies, with plans to extend donation programs and explore pricing options. And in an innovative mechanism, there is a plan to secure voluntary licenses from industry through the medicines patent pool to increase access to some of the newer drugs that are still on patent. Asco's contribution to the ATOM Coalition is capacity building, leadership development and education, as well as quality improvement, monitoring, and evaluation. So our main impact will be on the appropriate use with patients, not in the registration, forecasting, logistics, and supply chain. We'll let others work on that. And our main strategy when we work globally is to collaborate with other organizations to avoid duplication of effort and to maximize impact. And just a few of these organizations that we partner with are on this slide. We partner in research, we partner in advocacy and capacity building, quality improvement, and as you will hear about as we lead into our next talk, the American Cancer Society is a strong global organization, and we are proud to partner with them on patient education and support. Thank you very much for your attention as we explore our search for global oncology, and we'll have a joint question and answer to follow. Thank you very much. And I need to stop sharing.
Thank you very much, Dr. Grollo. We go now for the presentation of Dr. Knudsen, please. I think she will share the slides now.
I'm going to give it a try. Thank you. Let's see. It's coming, I promise, I hope. Okay, are we in presentation mode?
Yes, not in presentation form.
It is or it is not?
Not yet.
Okay, I think I have to do it this way. Hold on. Okay. Did that work?
It's in PowerPoint, but not in presentation form.
Oh, goodness. Okay, it worked in the practice. I'm so sorry for the technical difficulty here.
It always happens. Don't worry, Karin. We have time. It's great to have you here with us.
Okay, did that work?
Not yet, but no problem. We can go ahead with the PowerPoint. No problem. We can see your presentation very clearly.
Yeah, I'm so sorry about that. Or do you want to maybe present them for me?
But anyway, we have your presentation here with us. If you
Maybe,
prefer, we can.
Maybe we can do that.
Okay.
I'm so sorry.
Okay, I will ask in Portuguese, so sorry for that. Gustavo, pode apresentar então em português a apresentação da Karin?
Claro, claro. Just a minute.
Okay, we'll do it for you. Just a minute, please, Karin.
No problem.
Okay. Here it is.
Okay, so thank you so much for having me. As an ASCO member myself, I really appreciate the incredible presentation from Dr. Grallo and how impactful that organization is. And they've further intensified their partnership with us in the American Cancer Society. And I look forward to doing even more, including on the global scale. So thank you for having me. Next slide.
Pode passar isso.
Yeah, okay. Yeah, I have some disclosures, but they have no bearing on today. So we can go to the next slide, I think. Okay. So, the reason that the American Cancer Society exists and our key stakeholder are patients and families, from our perspective, is that the burden of cancer is unacceptably high. And you heard about the pillars from ASCO, and there's good synergy between us because of, next, can click again, I think, because we have a slightly different approach to how we address the cancer problem. In our case, it's through advocacy, through funding cancer science, and also directly supporting patients. Now, frequently in the United States, one of our major roles is actually to track cancer incidence, cancer mortality, and cancer disparities across the country. So, when we're thinking about the burden of cancer in the United States, it's significant. We right now in the US have an expectation in our own country of 1.9 million new cancer cases every year and more than 600,000 deaths per year. And while that is a high number, it's very small compared to the global cancer burden, which is what's here. We know globally that cancer is the second leading cause of cancer death, and with more than 10 million deaths in 2020 caused by cancer alone. And what I think is really striking is the concept that global cancer deaths outnumber the deaths of HIV and AIDS, tuberculosis, and malaria combined. So really a call to action of why we must address this global cancer burden. We're also expecting this global cancer burden, based on our own predictions from assessing trends, to rise to more than 30 million cases annually and 16 million deaths. This is a problem. We also expect, based on trends, that we will reach a point where 70% of the deaths, and we're close to this now, occur in lower and middle income countries. And we also are starting to see grave, concerning disparities that are also calls to action. And this is exemplified by colorectal or by cervical cancer, wherein the cervical cancer rates are, cervical cancer is certainly something that we can eliminate through HPV vaccination, and other countries are falling behind. And so this global burden of cancer is not distributed equally. What you're seeing here on the left is incidence and the right is mortality rates per 100,000 residents. And you see even between incidence and mortality, there's an unequal distribution about where this cancer burden falls. So then what can we do as cancer organizations, as global organizations, to reduce that burden is what I'd like to discuss, at least from the perspective of the American Cancer Society. Next slide. Okay, so we've also plotted out for you here just what the, can we go back one? That we plotted out for you here the age-adjusted mortality to incidence ratio, just another way of thinking about it. We have the US and Brazil there, with Uganda all the way on the other side, really just showing what the significant disparities are between countries like mine and your own versus places like Nigeria, Egypt, and Uganda. And so this is the kind of effort that we do. We'll sometimes then place our strategy in these areas of the world. Next slide. So the way that we approach this, as I mentioned, is our 3-pillar strategy through advocacy, through discovery, and patient support. And so what I'd like to do is talk about how our effort to reduce the global cancer burden falls within each of these major pillars. Next slide. So for discovery or funding cancer science, this is a hallmark of the American Cancer Society and something we feel is important to not only continue, but to accelerate. And we show this slide as an example about why funding cancer research is so important. So taking data just from the US, if we look at men on the left, women on the right, and cancer mortality over time, red is the line we would have realized had nothing changed. But circa 1991, there was a significant increase in cancer research funding from our organization, from the government, and other cancer organizations. And due to the breakthroughs in cancer research along the lines of prevention, detection, and new treatment strategies, we were able to avert, just in this country alone, more than 3.5 million deaths based on that new knowledge. And that is a 32% decline in mortality. So we are certainly learning how to avoid and to cure cancer. What's also of note is the curve of that slope. So that flattening of the curve started off with a 0.5% year-over-year reduction in mortality, accelerated to a 1%, and now we finally hit this 2% year-over-year reduction in mortality in the States. So we have much still to do here, but it is proof positive about the impact of cancer research. We ourselves, just since that time, have put more than $3.1 billion into cancer research. We are the largest nonprofit funder of cancer research outside the US government. Next slide. But what I also want to make clear is that we do research that that not only has a global impact, but actually funding research in other countries. And I will give an example of work that we're doing at present in Ethiopia. So we know from the global burden in Ethiopia that there's a significant opportunity to increase awareness, screening, and treatment of breast and cervical cancer. And so one of our strategies there is to fund population science research that helps to eliminate those barriers to access to care, currently supporting 2 graduate students, and to date, they've had 8 published articles. We're also working in that area on cervical cancer screening, so taking the research and putting it into action with a specific target by working with the academic centers to use that information to disseminate into the community. But then finally to work with the regional health systems in Ethiopia to gain access to care, not only for screening, but also for radiotherapy. So we're advising those regional centers about how to get care for patients that for which cancers are disproportionately present in that area. So we do have funding for cancer research in other countries when there's a need where we feel that we are uniquely poised to make a difference. Next slide. However, we know even in our own country that advances that we've made in research have not benefited everyone. We have a lot to solve even here in the United States. So what you're looking at here on the top is for all cancers, and the incidence and mortality, or I'm sorry, the death rates, mortality rates for men on the left and women on the right, wherein Black Americans are in the red bar, red line, and whites are in gray. So even, for all cancers, there is a significant burden on Black Americans that's different than on whites. And if you just take two of the most prevalent cancers, prostate cancer on the left and breast cancer on the right, you see that these disparities have really been sustained over time, despite the advances that we've had. And we look internally and we know in the States, what are some of these drivers of cancer disparities? I would argue that we actually understand them very well. It's lack of transportation, lack of access to housing near a cancer center so that someone can actually afford to be near a site of care. There are just overall gaps in health literacy and digital literacy. We know that financial toxicity is an important driver of someone's cancer care decision and leads to lower quality cancer care. Lack of access to health insurance, and also sometimes in our own country, just an unconscious bias where someone, because of where they are from or how they look, may not be offered actually the standard of care. So we see ourselves as working internally to the US, but also externally to take this knowledge, this understanding about drivers of cancer disparities and eliminate them through action. Next slide. So one of the ways that we can do that is through our second pillar, and that's advocacy. So here in the United States, we work at both the federal and the state level. Many of our decisions about healthcare coverage occur at the state level. So we have operations in all 50 states and Puerto Rico to do that. So we've developed a strong competency in working with elected officials to affect change, using that science as the basis to affect change. Next slide. But we're also using that muscle to try to develop that same type of competency with partners in global efforts. And I'll just give an example here of our Global Relay for Life. So right now we have a focus in our Global Relay for Life around advocacy with South Africa, Denmark, Zambia, and Zimbabwe. In the last year, our focus was on tools for combating cervical cancer, educating elected officials, as well as those that have the ability to make decisions about screening and about coverage. In 2022, we are focusing with an additional focus in South Africa, and organizations have reached out to us to try to help with advocacy, but also that there's a demonstrated need. And this is just one of the efforts that we're focused on at the moment. Next slide. So lastly, our third pillar that we utilize is patient support. This is one of the ones that's the most important to us at the American Cancer Society. This is where, for example, we educate patients and their caregivers across the country, but indeed across the world, about cancer. The patient support pillar is accessed by about 55 million individuals every year, many of whom come from the global community. We also work physically in 5,000 communities across the country, and now we're extending some of those activities to have a global reach. Next slide. So some examples of what patient support does, and I'm happy to answer questions about this, include working at prevention and screening in multiple countries, looking at how it is that we might enhance education and knowledge, but then also deliver toolkits to regional health systems and centers to enhance uptake of prevention and screening strategies. We also partner with a number of organizations under things that are really important. So you heard about access to drugs from Dr. Grelo and Asco. We also have partnered around the concept of safe handling of chemotherapeutics so that knowledge is available throughout the world for health systems. Patient support through navigation is something that we're passionate about. We have a strong presence in Kenya and Uganda, as well as other places globally, but in particular there to enhance patient navigation, and are working with a number of partner organizations toward that end. And then also end of life care and survivorship. So things that are really key that we educate health systems on globally that include access to pain relief and palliative care. In total, our patient support activity connects with 80 organizations in 57 countries, and by our last count, impacts about 600,000 patients and caregivers and 800 healthcare workers. So it's small compared to the world. It's small compared to what we would like to do, but from our perspective, every life touched is a life worth saving. So we're excited about what we've done and look forward to ideas for new partnerships. Next slide. Okay. One of the things that we have lifted up that's relatively new that we're piloting is a Beacon initiative, and this is to build expertise for advocacy and oncology navigation. This is being piloted in Kenya and in Uganda. It's a way for us to use peer learning to develop toolkits for cancer professionals that give them some training and technical advice from our global supported programs. This includes the navigation programs. And in just this pilot phase, where the goal is to, again, accelerate access to care, is to serve about 2,000 patients through Beacon. Next slide. And I will just also say that the reach of our global patient navigation efforts also include partnership with 2 organizations in Brazil. And so we look forward to doing more with you and learning more about the impact of what that Beacon initiative looks like. Next slide. And when it comes to patient education that many more individuals can access, we're aware that online usage is a great way for us to work. So our website, cancer.org, again, is built towards patients and families and now has wonderful connectivity with ASCO's website, cancer.net, so that we're really fully educating across the cancer continuum, everything from prevention and screening to treatment and survivorship plans. So everything on cancer.org is meant to be utilized by stakeholders with a broad spectrum of knowledge about cancer. So it's been important to us to translate that into other languages. So we've just had our first major accomplishment of taking everything on cancer.org and lifting it up into a complete Spanish website. And then we just launched that in the last year, and we've had so far more than 38 million individuals come and view that. So it was a big endeavor for us, a very costly one that took a while to put together, but we were able to do it. But we also provide cancer information in a large number of other languages that are listed there. So this is something that I not only hope that you would find useful, but also would invite feedback on if there's something that you think is missing or that we should add to the website. Next slide. Okay, so at the end of the day, this is kind of how we see our view of the universe, is that the way that we will end the problem that is cancer is through cancer research, and then using advocacy to enhance access to that. But in the meantime, patient support has to be part of this so that fewer individuals fall into these cracks where they're not able to access the kinds of cancer breakthroughs that flank that whole continuum from prevention to treatment. And then I just have another couple slides at the end here. I want to thank a large number of organizations that have come together across the US. This is just us meeting at the Asco meeting a couple of months ago. And with a large number of generally US-based organizations coming together with the idea that by working together, sharing ideas, and finding additional partnerships that we can and should do more to reduce the global cancer burden. And we're just getting started, but it has been a really wonderful journey so far. And I want to thank Dr. Grelo as well for being part of that. Next slide. And then finally, this is one that just really makes me so proud because of the speed with which we put it together, which is when there was the initial aggression in Ukraine, we realized that our online website was a way that we could get people access to information, as well as we have a 24/7 call center that we could get people information from Ukraine who may be displaced from care or having trouble finding care if they had left the country. What we don't have are oncologists on our team, a deep bench of oncologists. So a quick call to Asco, and we put together a volunteer corps that now has more than 400 volunteer clinicians in it. We set up 6 call lines with 6 different languages for individuals to call from Poland, from Ukraine, from Russia, from Moldova, to get information about cancer and to navigate to care. And so we're just incredibly thankful to ASCO and also my own former cancer center for helping us lift that up in truly what was 48 hours of time. And I think that I love this example because it speaks to how much we can do quickly when we take what each of us are excelling in and then put it together to address an urgent. So I think that's my last slide. Let's see. Now, just a summary, and I think I've talked about this already, that we want to do much more. Cancer disparities are all of the things that we talked about with patients not being able to access care. But it's also a disparity that's geographic across the world, and we find that unacceptable. So I look forward to partnering with all of you, and I think as I said there at the bottom, the philanthropic organizations do have a major role to play in reducing the global cancer burden. So thank you for having me, and I look forward when it's time for any questions. Thank you.
Thank you very much, Dr. Knudsen. Excellent presentation, very clear, very important. We can start now with our QA section. Maybe one point that we can start is when Dr. Grello mentioned the last meeting that involved different stakeholders, or maybe all the stakeholders, what are the conclusions of this meeting, especially related to the cost of cancer treatment today?
So great question. We are currently writing a call to action. We as Dr. Knudsen said about our disparities going on in the US, we know what a lot of the problems are. So now we need to work on what are the solutions. So we actually have a white paper in the works that summarizes just some of us. We don't know what everybody else is doing. So this call to action, this white paper is, let's share what we're doing and not try to reinvent the wheel. We will have a follow-up stakeholders summit. Just this morning, I got the invitation to it, hosted in Geneva during the World Cancer Congress as a follow-up to see where we are. I think, you asked about, we can't do everything at once. We need to have pilots and evaluate and learn. But I think the most important thing is that it's not a simple fix, getting everybody access to treatment. And that, there are multiple methods and pilots going on right now, from donation programs to discounted pricing to regional procurement. You have the PAHO, model of regional procurement, but it's not working very well. And PAHO will be the first to say that's not the answer either. We have the St. Jude model for pediatric cancer, but this is where they're paying, for the drugs and doing it as a pilot. And we're talking with World Bank and those who are involved with, global financing, the Gavi and the Global Fund, about, is there a potential for this? So we need the drug manufacturers at the table. We need the governments, the ministries at the table. We need those delivering the care. We need the patients and the patient advocates all at the table to get this to work. So that was a long answer to what's happening. The short-term answer is we're writing up all the different projects that were described and having a follow-up meeting. And every 6 months, we will continue to bring this group together, bring in other groups that are doing great projects. And of course, what we realized at our stakeholders meeting is that although we tried very hard, we didn't do well enough at getting actually the representatives who live in the low and middle income countries that we're trying to help at the table. So lots going on there, lots of work to be done.
One of the things that impressed me the most is that it's increasing the out-of-pocket participation all over the world. I don't know if Dr. Knudsen and Dr. Brello would like to make some comments about the out-of-pocket participation, but because this is directly to the patient, directly to the family economy, the problem is directly to them.
Yes, and that's something that I think does require, as part of the solution, advocacy with elected officials. You know, we have to go directly to those who are making the decisions about what's covered and what is not, and making them aware about the impact of the cancer burden, the financial cancer burden on their population, but also on, you know, there's a business case to be made as well on their own economy of their you know, their city, their province, or however their distribution is put forward. You know, we just came out, for example, with an article that was published yesterday and released that just showed the impact of cigarette smoking within the United States. Their lives lost, hundreds of thousands of lives lost, and more than 2 million years of lives lost, but $2 billion of productivity from the economy. So even just taking aside that it's the right thing to do to help your people, like, let's take that as a given. There's also a business case to be made. And sometimes with an elected official, you need that additional information.
And I would agree with that. We had maybe a small win in this area in this last week with our reconciliation bill, where it's now, you know, written into law that at least if you have Medicare, that you cannot have more than $2,000 a year of out-of-pocket costs for medication. That's still a lot of money for many people, but as Dr. Knudsen says, a lot of this needs to be done at the policy and advocacy level. You know, I also think that we, the treating oncologists, do bear some of the burden in how we define value and describe added benefit per cost. So a bit of this is on us. And I'll just tell you a short story. Early in my global oncology career, I was in Uzbekistan and meeting in a doctor's office, and he brought in a patient and her whole family, and they very, very proudly, the country covered tamoxifen for early stage breast cancer, but it did not yet cover the aromatase inhibitors. And but the physician very proudly told me that the family who was standing in the room paid out of pocket for the adjuvant aromatase inhibitors because it was so much better. And I thought, you're bankrupting this family for a marginal benefit, and you know, they would do anything for their mother. But in my mind, I knew, yes, there is a benefit, but it's not that much. And is it worth it? And so that story sticks with me. It's on us as the treating physician to make sure that we understand the added cost when we add some of these new targeted therapies that have minimal benefit. You know, we really do have to be careful about how we define value. We have to look at the efficacy, we have to look at the toxicity, and we have to look at the cost as well. So we bear some of it in our discussions with patients as well.
I think that the one important question is related to education, not only to education for the professionals or for the patients, but for the entire community What do you think about this, and what age is the best age to start the education process?
My personal bias is the earlier the better, right? To start the education process just about health. And if you think about the importance across the world of getting uptake for HPV vaccination, that almost invariably then requires the conversation to start earlier. You know, here in the States, we still have problems with HPV vaccination uptake. I can't tell you how many times I sit next to someone at an airplane and they have no idea that boys should be vaccinated. And it's just mind-blowing to me all these years later that we've not been able to communicate effectively about the importance of HPV vaccination. So I think earlier rather than later is good. My personal bias is that giving individuals the right tools to talk about their own personal health and advocate for their own personal health, to be able to say things like, what should my cancer screening plan be? Right? And not wait for someone to tell them, could all by itself be empowering. So my bias is, I think we need to start early rather than later. But I also think that we need to attend to digital literacy as well, because so much of what we deliver in cancer care is going to move to a digital space, and individuals will be able to access the kind of thought leadership that Dr. Grelo just talked about, of whether or not an aromatase inhibitor is appropriate or not for a patient. You know, having a second opinion from someone who's an expert in that area is now possible, right? Because of digital technology. So familiarity with using digital technology, I think, will be an important addition to health education.
And I think early, I agree with Dr. Knudsen, early is appropriate. I mean, all of the lifestyle factors that impact our future risk for cancer impact our future risk for heart disease, diabetes, and many other diseases. So early on, teaching about the benefits of healthy lifestyles, not smoking, physical activity, healthy diets, bring in the vaccines as appropriate at that age. I've seen some great campaigns around the world where focused on Mother's Day, where in the schools, the children learn a little bit about health screening for cervical cancer, breast cancer, et cetera. And then as part of Mother's Day, create a little card and say, please get your cancer screening, Mom. And I love that idea too. So teaching young can also hit the next generation or two.
What a great idea.
We still don't have questions from the audience, but we can ask Daniela, Luciana, or Brazil to make some questions.
Thank you, James, and thank you, Dr. Knudsen and Dr. Grelo. I'd just like to make some comments and a question for you too. We have a great challenge in Brazil because 75% of our population has a public health system coverage. So they get all the drugs for free. And I think this is amazing. I'm very enthusiastic about that. Of course, when you talk about cancer, oncology, globally speaking, we know that we miss a lot of drugs. For example, in breast cancer, we have tamoxifen, we have aromatase inhibitors, but we don't have fulvestrant. So we have to ask for and go to the justice and so on. And of course, we don't have CDK4/6 inhibitors, of course. And having said that, I know that we have to talk about doing HPV vaccination, doing more screening for diagnosing breast cancer in earlier stages. But we still have a big part of the population that will have their breast cancer diagnosed in stage 3 or 4, for example. We have double the number of people having stage 4 breast cancer in the public system when we compare it with the private system in Brazil. So how can we manage, how can we deal with the increasing costs of new drugs in oncology, in all fields of oncology? And of course, breast is a great example. This year we have too many new drugs for breast cancer treatment. For this population, how can we include this in the budget? I think it's not a problem only in Brazil, it's a problem in the world. What do you think about that?
It's a great question, and I think some of the the problems that we create in the United States with respect to how drugs are priced have effects all across the world. I've been very disappointed at what's happened with the introduction of biosimilars, for example, and how it has not really driven down the price as much as it should have, in large part because of who makes and buys up and owns the companies that make biosimilars. So there's not as much competition. I think there are some companies now that have, for example, some Me Too drugs, if you will. It's for drugs that are still on patent, but they've been developed, for example, in China. And so immune checkpoint inhibitors, CDK4/6 inhibitors, EGFR targeted therapies that have been tested and approved in other parts of the world, but aren't in the US, but with the intention to really disrupt the price, if we can figure out how to get them approved in the US and in Brazil and in Europe, et cetera. I've been told that the WHO's essential medicines list is willing to take applications of drugs, some of these Me Too drugs, in those categories I listed, and apply, because the way they evaluate is the efficacy, the toxicity, and then the price, right? So they would be willing to review sugemalimab, for example, a Chinese immune checkpoint inhibitor that is much markedly reduced in price, and only put that drug on the EML for certain diseases. So I think we need to disrupt the current status quo a bit. We need some competition. And I think our governments, our regulatory agencies, our ministries are going to have to help a bit with disrupting the current status quo, because it's not working. Every immune checkpoint inhibitor in the United States costs between $8,000 and $10,000 a dose. And every time a new one gets approved, the price does not go down at all. They all come in at the same price. So in a lot of ways, there's a policy and advocacy piece to that too.
Yeah, there definitely is. But, and I think part of that also is just gathering the data. So, you talked about that, that fulvestrant, gap in Brazil. And so marrying that gap with the number of individuals who would have benefited from fulvestrant, and how many people is that, and how many lives lost is it? How many, what's the impact? I'm going to lean back again and make the health economic ploy, because that tends to get elected officials actually thinking alongside the humanitarian, right thing to do argument. So, I think marrying the real needs, and instead of trying to boil the ocean, say, all right, in Brazil, our biggest challenge is this, this, and this. What's your top three? I'm making up three, but what's your top threshold? And then if these drugs were available, what would be the benefit to the Brazilian population? Can be a nice accompaniment, not replacement, but accompaniment to the really wonderful things that Dr. Grelo talked about, including the adding Me Too drugs to the WHO list. So that would be
both economists can be our friends there too, creating packages and doing estimates of how many lives would be saved, et cetera, for how much cost.
Yeah, great. Brazil and we are involved with the City Cancer Challenge in Porto Alegre, so we're working a lot to set up the prostate and breast cancer guidelines for the city. And it's a challenge because we're facing some difficulties where we want to recommend all the drugs that we know that are important in all the timeline of the patient. But on the other hand, we know that we are not getting that. And so we have to work with people from like the Brazilian government to show them that is important. So it's a big challenge that we have. It's not only setting up guidelines that we are used to do, it's how to put them in practice. I think this is the big challenge that we have.
Well, the time ran away very fast. We get into the final of this meeting already. And but anyway, we are talking in global oncology. The specialty has the benefit to be well structured and based on evidence. And so we talk the same language all over the world, and this meeting can prove this. And we can do this more frequently. So unfortunately, we are in the end of the meeting, and I would like to thank again Dr. Julie Grallo, Chief Medical Officer and Executive Vice President of American Society of Clinical Oncology, USA, and Dr. Karen Knudsen, Chief Executive Officer of the American Cancer Society and Cancer Action Network, USA. It was a great pleasure to have you both here with us, and I hope we can do it again very soon. We are waiting for Dr. Grallo in Porto Alegre and hope that Dr. Knudsen can come to visit very soon too. Thank you very much for the attention of everybody. We are finished now.
All right. Thank you, everyone. Thank you for having us.
Out of the streaming now, but we can